Welcome, welcome, welcome in, everyone. Welcome to Care Concierge with Carepatrol, where education is the heart of everything we do for our clients. And we like to bring education to you as well. So thank you so much for being here on another beautiful Monday. Um, we are, if you're new to us, Care Patrol is a referral and placement agency. And what that means is we advocate for our clients and their families, educate them on options for care, and then show them those options if those include community options. And we tour them like a realtor would. And we're sort of paid like a realtor in that we are paid by the provider, the seller, if we help them find a potential client or resident. Uh, our typical process is interrupted today. If you'll look in the chat room, I have placed our instructions for the day. We normally use an evaluation survey called Survey Monkey. But today, for whatever reason, that site is down. So if you will, go ahead and email me that you are here in attendance, and I will send you a certificate. If you're a nurse, and everyone, please put your number, license number, and type so that if you are a nurse, we'll be posting that for you, and everyone who emails me now will get a certificate or throughout this presentation or really before 8 o'clock today. I hope that's clear with everyone. And if you have any questions about our process, just please, unable to email outside of the UAB system, Ms. Sheffield. I wonder if you can get an email from me. If you have a personal email, perhaps that would work. Otherwise, I'll try and figure something out. Is anyone else having issues with the need to email me today instead of using our evaluation process online, which is not working? Ms. Sheffield, we'll figure something out. Our topic today is beyond the diagnosis, intersecting chronic conditions and social. Thank you, Miss Willis. Let me copy that real quick before I lose it. Thank you so much. So our objectives today for beyond the diagnosis, intersecting chronic conditions and social determinants of health in older adults has three objectives, which I hope we meet. Those are one, to identify or define, the social determinants of health and list the 5 key domains that impact well-being. Our second objective is to explain social determinants of health factors, connections to the management of chronic common conditions. And our third objective is to identify practical strategies and resources, we hope. And I'd like to do this with your help. I'd love your input here on identifying practical strategies and resources. So what I think, all know is that healthcare, really happens at home. And we know this. To truly help those people who are with us for a short time and are given instructions as to how to manage their disease, really to understand that best and truly help them, we need to understand the social and environmental factors that impact their ability to follow those instructions and directions and manage their own health. And studying this, obviously, we're studying social determinants of health. And what we want to do today, I hope to do, is to deepen an understanding of how these conditions, SDOH, critically influence presentation, management, and outcomes with older adults. And we'll explore connections to try and enhance some advocacy and intervention strategies as well. And I may have said early on, but I always want to stress that we really value your input and hope that you enhance the discussion. To do so, go to the chat room and add your thoughts to mine. So let's get started then. Who knows what are the social determinants of health? Who knows? If you know the answer, please go to the chat room. The chat room, if you're new to Zoom, move your cursor to the top of your screen. A black bar should drop down. If not, move it to the bottom and a black bar will pop up. On that is the word chat. Click that and add your thoughts to mine, as I know we'll all be enriched. So, the 5 domains of the social determinants of health are: one, economic stability, and this includes everything from employment and income to debt, including medical bills, and even includes things like food security and housing stability. There's education access and quality, which is, of course, literacy, one's ability to communicate and understand communication, vocational training, and higher education access. Our third, or the third rather, uh, uh, key domain is healthcare access and quality. And this would be obvious access to healthcare good, Ms. Sanders. This would include insurance and the ability to access providers, including the neighborhood and built environment. So, where is housing? Is there transportation? Is there accessibility to healthcare and even to healthy foods? And then the fifth domain is the social and community context, which includes all of those support systems in place, community engagement by the individual, and also includes discrimination and exposure to violence. And these, I think you know, are not abstract rather concepts. They are daily realities shaping clients' health. And so I think we're seeing a shift in perspective then from the social determinants of health as being possibly more fundamental causes of chronic disease. And so the evidence is really becoming clear. Social determinants of health are increasingly acknowledged in paper after paper as a fundamental cause of chronic disease. Studies show that these social factors can influence and initiate the onset of pathology. So, our role today, I hope, is to understand and address these root causes beyond what you know to be the resulting conditions. So, let's define, as we said we would in our objectives, let's define social determinants of health. And let's use the WHO, the World Health Organization's broad view at that social determinants of health are the conditions in which people are born, grow, work, live, and age, and the set of forces and systems shaping the conditions of daily life. Variables directly relevant to chronic disease include the social practices and conditions of the individual patient, including their lifestyle, their life, their work, their neighborhood, their poverty level or income level. There is their income, education, and occupation that we need to be aware of when assessing. any stressful circumstances that they may be under, and we'll touch on this, including racial discrimination. And this will help us move more from the broad WHO definition of social determinants of health, and hopefully then look at some specific actionable things that can be done. So just off the bat, can you think of any of these 5 incidents or 5 key domains of social determinant of health having an effect on your patients? Can you think of any incidents? Is this something you face daily and are well aware of? Is this something that doesn't come up? Can you think of any of these key domains as having an effect on any of your patients? Perhaps you have one in mind. Ms. Tony says, patients who do not have access to transportation or patients who do not have insurance. Yes, that's a great one. Well, let's look at some more detail. Is anyone familiar with what are called the Whitehall studies? You may have had this in school. It's one of the most powerful illustrations of social determinants of health in terms of having what's called a social gradient. Social gradient. This was demonstrated by Sir Michael Marmot in the Whitehall studies of British civil servants. So he had 2 major cohort studies of British civil servants that fundamentally over time changed our understanding of health inequalities. And so why was this groundbreaking? Well, the reason is that these Whitehall studies studied a population that was stable, that was considered white collar employment, and where everyone had universal access to the National Health Service of Great Britain. So healthcare, there was no expense like we face in the US. So the studies then were able to control for unemployment and unequal healthcare access. And this allowed the researchers to isolate and investigate direct health effects of social hierarchy itself. And the research revealed that there isn't simply like a little simple dichotomy between rich and poor, but that health outcomes follow a distinct and stepwise pattern across our entire socioeconomic spectrum. The first study in 1967 revealed a shocking pattern. Now, look at it. They were studying over 18,000 male civil servants. And their primary finding was that there was a steep and inverse association between the employment level or grade of that person and their mortality rate. So men in the lowest grade of the study, who were things like messengers or doorkeepers, their mortality rate was 3 times higher than men in the highest grade, the administrators. And so the risk of death was not just a problem for the lowest grade, however. It increased incrementally at each step down from the administrator, the highest grade. An executive officer had a higher risk than a senior administrator for which a clerical worker had a higher risk. If that makes sense. That was a lot, wasn't it? Excuse me. The key outcome was that what they most saw, and the reason for this, was coronary heart disease of those persons at the lower level, but it applied to a wide range of other diseases as well. So in 1985, Whitehall studies were resurrected. Only this time they studied women, because women had entered the workforce as well as men, and these were over 10,000 people who were such studied. And their focus in the second Whitehall study was to move beyond what was happening, that this social gradient had an effect, and to understand or investigate why it does. So it examined the psychosocial mechanisms that link us in social position and are directly reflected in our healthcare. So the key mechanisms that they identified said that this was not a traditional risk factor like smoking alone, but a psychosocial factor relating to their work, which included those with low control over their work and decisions have a higher mortality rate. Those that have high effort but less pay or less reward, perhaps working in a laboring type position, those people have a higher incident of mortality. When there is poor social support within the workplace itself, we see this has an effect on people, and particularly when one experiences a sense of injustice or unfairness. These were all identified in the second study and confirmed that chronic stress of one's position in a social hierarchy has a direct pathway to poor health. Then there were additional studies, of course, there's been many studies. The Cockerham studies in Great Britain presented a different framework, and their central argument is that assigning disease causation solely to biological anomalies is insufficient. They position in the Cockerham studies that social factors are not secondary influences. They are increasingly recognized as the fundamental causes that initiate the onset and determine the course of chronic illness. Now, this perspective is essential for our work in moving forward. Is everybody following me? Anyone disagree with anything thus far? So, according to the research in Cockerham, the most critical factors, social factors determining health outcome or income, this is not surprising, accumulated wealth, which is a new idea, education level, occupational characteristics such as less control over one's environment, and then the social inequality that exists based on our race and ethnic group membership. These variables in the Cockerham study have a direct effect on the lifestyles, risk behaviors, living conditions, and stress levels of the individual, which creates a clear pathway to chronic conditions like cardiovascular disease, type 2 diabetes, cancers, and kidney disease. There's been a rise, as I said earlier, in research. So this is a paradigm shift for perhaps for some of you, but it is a growing body of evidence to suggest that it's worth taking a look at. In 2006, there are only about 88 papers on social determinants of health. In 2015, there were over 1,000. That was 10 years ago. So imagine how many more have come about. And what it shows us is that there's some critical importance in integrating social determinants of health into clinical and community practice. So we want to look a little even deeper now at some of the further research in terms of social determinants of health and key theories that have come about. One is called the life course theory, which says that health outcomes are a cumulative result of advantages and disadvantages over a lifetime. The fundamental cause theory of social determinants of health positions that economic status is the fundamental or a fundamental cause because it shapes access to resources that can be used to avoid chronic disease and its consequences. There's the social capital theory of social determinants of health. It says that our social networks and relationships provide resources, including support and information, that are vital for health. So imagine if you have someone that has a vast social network, they're likely to get more ideas about how to treat their disease. But someone who's isolated because of whatever reason is less likely. And then there's the health lifestyle theory of social determinants of health, which says that the collective patterns of health related behaviors are shaped by life chances and life choices. They all kind of hit upon socioeconomic factors as having an influence on the onset and progression of disease. So, what types of behavior? This is kind of it may be an interesting thing to think about. I hope. I'd love to hear your opinion. What types of behaviors might be said to involve social determinants of health? Or, in other words, social determinants of health might lead to what kind of behaviors in individuals? Does anyone have a guess? What lifestyle or life habit or life choice might be a behavior that would lead to chronic disease? Substance abuse. Very good. Thank you, Miss Elder. Smoking, Miss Lee says. Drug usage, Miss Hamilton. Thank y'all for understanding my question. It was a little bit of a mouthful, and I appreciate your comments. So, smoking is really the one that comes to mind for me. It's a clear example of a health behavior that's driven by social determinants, and smoking we know to be associated with at least 21 chronic diseases. And most people begin smoking through social initiation, peer pressure. They may grow up in a smoking household, or they may be around others who smoke, and it creates a powerful pro smoking environment. So there's a social gradient, I'm sure you know, or you can certainly guess, to smoking. Beginning in the 1960s, those who had higher education or were in more affluent groups began quitting smoking in large numbers. So that today we see that smoking is concentrated among those who are typically in socially disadvantaged circumstances, and that this may compound their need to smoke due to the debt and stress work level against quitting, if that makes sense. Cardiovascular disease is another chronic condition that is exacerbated or influenced by social determinants of health. In fact, it was the primary outcome that was measured in the Whitehall studies, and it showed, as we said, a threefold increase in the mortality risk for the lowest ranked civil servants, and that was driven largely by heart disease. So it demonstrates that social determinants of health, including work stress, lack of control, a diet shaped by income, and smoking patterns, could be direct causes of pathology, not just correlated risk factors. Let me ask y'all, what percentage of your patients do you think live in so-called food deserts? Are you familiar with the term food desert? A food desert is any area in which food, access to quality food, grocery stores, is not able to be had. So people do most of their shopping in convenience stores. Miss Tony says 30 to 40%, Miss Willis 30%, Miss Fonstock 25%, Miss Townsend 45%. That's alarming, y'all. 45%, 35, 25%, any percent in the United States is alarming to me, where we have more food than the rest of the world. So as we look at hypertension then, and the SD and the intersection with social determinants of health, we can see that chronic stress is a leading cause. Financial insecurity, debt, and poverty directly contribute to elevated blood pressure. We know this. We know that for many, Miss Holyfield, 50, wow. The cost of meds, we know that non-adherence to cardiovascular drugs is in part driven by someone's inability to afford them. We know that this person may also have a lack of transportation or insurance that guarantees their access to health care to monitor and manage their disease. They may live in a neighborhood and built environment in which they're in a food desert, as we said, in which they have low access to low sodium options. Everything is canned and boxed. And they may be in a neighborhood where it's not healthy or advisable to walk or be active and exercise. So there is a social gradient here involving cardiovascular disease, which is related to stress, related to the lower rank of the person within the social hierarchy. This is what Whitehall said. This is what Cockerham said. And there is then perceived discrimination at Act 2. Chronic stress from racial and ethnic discrimination is well documented as a driver of hypertension. Let's look at arthritis and its intersections with social determinants of health. One, we know that someone who is in a laboring type position is going to be more physically demanding in terms of their health and their job, and that osteoarthritis can be exacerbated by this over decades of work. We know that someone in a lower caste system may not be able to afford either to take off work to do or even afford physical therapy or even assistive devices in the home. We know that the cumulative physical burden of manual labor over a lifetime contributes directly to the severity of osteoarthritis in later life. And then there's a lack, again, perhaps of walkability, that someone may be exacerbated and not able to get out. The issue here with social determinants of health in many cases is the difficulty in health literacy of the patient to understand how to manage their osteoarthritis, because perhaps they don't have the ability to do so. Diabetes, another chronic disease, and we're looking at chronic diseases and their influence or their intersections with social determinants of health. So food costs clearly would be a representative of an economic instability. And we know that Whole Foods is a lot more than Aldi, right? And in Whole Foods, well, frankly, Aldi has great vegetables. That's not a good comparison. If you haven't been to Aldi, go to Aldi, and I'm not paid for that. We know that insulin high cost can directly lead to disease and mismanagement of type 2 diabetes. And we know that food choices are not just individual decisions. They're shaped again by life chances. If your life chance places you in a food desert, it's not that you don't want to be healthy or eat healthy. It's that the options for you to do so are limited or not at all. And so the other issue with those folks who are having type 2 diabetes issues or their health literacy and the challenge in understanding a complex diet plan and the inability to adhere to it or to even monitor one's blood sugar. And then we see increasingly that there are language barriers. We have difficulty in educating certain clients because of a language barrier. That's a social determinant of health intersection. Let me ask y'all, and I don't know how many of you see elderly or aging patients, but if you do, let me ask you, do you have time typically to do a mini mental exam screen? Do you have time typically to do a mini mental exam screen when you have older patients? Is this something you have time to do? Is this something you do? Is this something you feel needs to be done? The nurses here do a mocha, Miss Tone. Oh, well, even better. Miss Watson says, yes, thank y'all for yes is needed, Miss Clark. I used to work with seniors, and yes, I would do an MME. That's great. So, because our next social determinant of health intersection with chronic disease is the chronic disease of dementia. Ms. Nick says we use a MOCA or similar screening. We're able to do it in a dedicated visit. Oh, I love that. Yes, when needed, says Ms. Pittman. So with dementia, we see a direct relation to the social capital theory that we discussed earlier, where someone who has community engagement in their life, that has a network, perhaps a vast network, this is protective against cognitive decline. Studies show this. And studies also show that social isolation is a major risk factor for developing dementia. We know that higher educational attainment is linked to greater so-called cognitive reserve, which may potentially delay or even offset the onset of symptoms. And this is a classic example of how early life social determinants of health impact our later life health. The access that we had to education and the ability to keep our minds engaged and the ability to not do hard labor, as we discussed earlier, which leads to things like osteoarthritis and exacerbate it. We know that with dementia, access is key. So many times patients are not seen from underserved communities or who are isolated and otherwise unable to get the window of diagnosis such that they might forestall the dementia through medication or other things. Hearing loss, often confused with dementia, and economic stability is a primary driver in terms of a social determinant of health affecting a patient's ability to live in this world. Hearing aids, as we all know, are prohibitively expensive. The last number I heard was over 4,000, and that may be low. And they are then therefore considered not essential, but rather a luxury good. So if you have the ability to either A, pay your rent, or B, hear, most people are going to play the long game and pay the rent. There is a social and community context with hearing loss in that we see that untreated hearing loss is a direct pathway to social isolation. That's no surprise, is it? As communication becomes frustrating for both parties. And we know that hearing screenings are often overlooked, particularly in underserved and overworked clinics. I wonder if y'all know, how many doctors do most Americans see? Can anyone guess? How many doctors are most Americans seeing? 5, says Miss Nix. 3, Miss Watson. 2, Miss Willis and Miss Creswell. How many doctors? Miss Townsend thinks 8. Miss Harris, 3. Miss Mann, 4. How many doctors do most Americans see? Miss Hurd, 5 to 7, depending on conditions. Those of you who guessed 5, and it may not have been a guess, were correct. 5 physicians. Now, what do physicians typically do? They typically prescribe, don't they? Physicians typically prescribe perhaps a treatment, perhaps they recommend therapies, but they typically also prescribe medications. And so if you're seeing 5 physicians, it's likely that you're taking 5 medications. In fact, you may be taking quite a bit more. And polypharmacy intersects with social determinants of health in these ways. We have a very fragmented healthcare system where we may see 5 specialists who, because their records don't intermingle via their softwares, do not share information with others. And so we have all sorts of different medication regimens in which one may be contraindicated for another. You know this. And so that is a direct call, or is. It's just the definition of polypharmacy. And think about this. If you're seeing 5 doctors and you're taking 5 pills, and one is 2 hours before a meal, and one is 1 hour after, and one is 3 times a day, and one is as needed, how do you keep track of that at any age, but certainly as we age? And then how do we pay for it? So again, we may see people foregoing insulin or hearing aids or cardiovascular medication because they can't afford it, because they were in the lower rung of this social hierarchy. And this social hierarchy affects mental health as well. Depression is one of the top chronic diseases in the US. And the Whitehall studies show definite factors that decline with social position, factors that would lead to depression. One is self-esteem. One is control over one's environment. And one is a sense of social support. These all affect us in terms of depression. They're all risk factors for depression. And we see that people who are depressed often have weak social capital, and loneliness is a powerful prediction of dementia in older adults. Then there's the economic stability that depression can be had because we can't afford to live in this world. And we live with that stress and we live with that risk factor. Ms. Hurd says, when I had my nursing students do medication management for the senior program I supervised in Oregon, they would find sometimes 2 to 3 literal bread boxes full of prescriptions from multiple prescribers. I don't doubt it. That's so alarming, and it doesn't have to happen. Incontinence is a top chronic disease in the US, particularly among the elderly. And there's a stigma to incontinence, isn't there? There's a shame that the person would feel, and this shame would lead to a reluctance to discuss and may delay diagnosis and treatment. They may have lack of access in their home and built environment, a key component of social determinants of health. And the high cost of incontinence products can be a burden on folks. In fact, what do you think is the average annual amount spent by an individual in the US on incontinence briefs? Average amount spent on incontinence briefs in the US. Does anyone have a guess? I was really stupefied by the number, I'll tell you. Miss Tony guessed 2,000. Anyone else guess the average? 2,000, says Miss Wesson. The average annual amount spent on incontinence briefs by someone in the US is $5,000. $5,000. Now you tell me, if you have worked a labor level job your whole life, you are living on Social Security and maybe a small pension, and you're trying to afford rent and healthy food and hearing aids and incontinence briefs, it's just not going to happen. It can't happen. It can't happen. So that is some of the top chronic diseases intersection with social determinants of health. Now let's look at how discrimination in health, or perceived discrimination in health, intersects with social determinants of health. The Cockerham study identified racial discrimination as a key social determinant of health. This is not an abstract concept, and it has physiological consequences. Chronic exposure to discrimination throughout one's lifetime acts as a significant psychosocial stressor. And this stress contributes directly to the pathogenesis of certain chronic diseases like hypertension and cardiovascular disease. And this key determinant of health, this racial discrimination, may explain, in part, the persistent racial disparities in the health outcomes of those with these diseases. Ms. Nix, thank you for your comment earlier. So, where do we intersect then aging adults and social determinants of health, which is what we focus on at Carepatrol, aging adults? I know many of you see aging patients. So many older adults have multiple morbidities, multiple chronic conditions, and these are compounded by various and adverse social determinants of health. And this is really complex, and it's not typically the case that a single intervention is alone and justified and needed alone. The challenge then, as clinicians, is to try and develop care plans that account for these intersections. So addressing, for example, one's diabetes and arthritis as being related in part or large to their food insecurity and unsafe housing at the same time. Does that make sense? So in addressing fundamental causes, you on the line here are uniquely positioned to bridge the gaps between social determinants of health and top chronic diseases. You can integrate these into your routine, and the way to do so is to ask the why behind the clinical problem. And you can use evidence from Whitehall and other studies that you may find that helps you advocate internally for care plans that prioritize quality of life, autonomy, and stress reduction. And really, your core function remains, I think, the same: resource navigation. Be a conduit to your patient to resources that can help them overcome these barriers, these social determinants of health intersections with their chronic disease. So practical strategies, as we said we would address, may be working with your physicians and pharmacists and patients to de-prescribe, to have a medication evaluation and see where we have issues, to make sure that all of the specialists have the same information. And you can always connect clients in terms of nutrition to SNAP, if it remains in effect. Meals on Wheels and other local food assistance programs. And Meals on Wheels, I mean, they're not great meals. I don't know if you've ever had one, but I mean, it is healthy food, and that is a plus for some of our folks. You can help folks in social connections and intervene and help them understand access and places to go for information and help, like senior centers. You can do a home safety assessment if you are a nurse or social worker who does home health or hospice and you're in the home. Do a home safety assessment, move the cord out of the floor, move the box out of the way. And then you can use teach back methods, as I'm sure you already do, with your clients, in which you explain to them how to better manage their diabetes, for example, like eating different foods, and then have them teach back that to you, knowing now that they understand it, particularly when we have a language barrier. And I asked in the beginning, and I'll ask again, do you have any other resources or practical strategies that you can place in the chat room for the benefit of your colleagues on the call? Do you have any practical resources or strategies that you can share that would help you intervene when social determinants of health are directly relating to the patient's presentation, if that makes sense? And as we wait on your answers in the chat room, I'll say that we want to sort of take the evidence we've talked about and synthesize that and say we want to go from just simply looking at social hierarchies to health. So we've moved beyond listing risk factors in terms of social determinants of health, and we're moving into calling those fundamental causes, not simply risk factors. And the research here is unequivocal. The social context of a person's life is a primary driver of chronic disease. And Ms. Nix says, I think it depends on the individual's needs, particularly since they can vary and there's not a one-size-fits-all resource. I think that's very wise, Ms. Nix. As the Whitehall studies demonstrated, health is not random. Remember, we said health starts at home. It starts in the person. It starts with where they come from and how they got there. The chronic stress identified with positions of low control, an effort reward imbalance, and a sense of injustice is a direct physiological pathway to hypertension, heart disease, and depression. Interventions, therefore, are not just supportive, they are essential. So moving into action, the Whitehall studies give us a mandate, which is that the role of the clinician extends beyond managing symptoms to helping mitigate the root causes of the illness. And that would require a commitment to assessing for psychosocial stressors of social position, assessing for someone who's experiencing low control, assessing if someone feels a sense of injustice in terms of their position, and that they feel if they have poor support in maintaining that position, and do this assessment with the same diligence as the assessment of physical needs is done. Commit to advocating for clients and validating that these real life experiences have had an effect on their health and can be mitigated. And intervene as possible by connecting individuals to resources that you are aware of that help them build autonomy and social capital and reduce systemic stressors. And if we can address these fundamental causes, we can elevate healthcare practice from simply caring for the sick to actively building healthier and more equitable communities that will, again, mitigate the onset of chronic disease. And here I have a comment from Ms. Tony. We use a prepare in my clinic. I use it to gather information for SDOH and I ask open-ended questions. If there are areas of concerns I can assist with, I refer the patient and follow up as many times as needed. Follow up is very important. It sure is. I follow up with my folks. Well, it depends, but everybody gets followed up. If I move you somewhere, I follow up at first every month and then every quarter. But throughout the process, like I sometimes talk to people for years, and so I'm sure you do. And you just have to follow up, every so often. Have you done this? How is this? How are you doing? I love that you do that for your clients. So ignore that screen. Again, I had issues today with my evaluation software. Normally, we have you do an online evaluation and I email you a certificate. In this case, I'm going to ask you to email me at the email I've just placed in the chat room to say that you were here today. If you want a certificate, email me. My email is my name, first initial S Barnes, Barnes, at carepatrol.com, carepatrol.com. Email me now that you have watched this presentation, if you're watching it on YouTube, or that you've been with us today. Email me and you will receive a certificate in the email. If you are a nurse in the state of Alabama, email me your license number as well as social workers' license number. Nurses, we will post the survey or post your hour for you on the ABN website. Nurses and social workers, email me to get a certificate with your license number, please, and I will send you a certificate. I've put my email back in the chat room. Does anyone have any other questions or comments? Since we have a little time, please not in the chat room, Miss Hightower, because I don't have an ability to take that information from this chat once the Zoom is over. I'll try and copy it now. Maybe I'll hold, but please email me, not the chat room. And thank you so much for being here. There's still 90 of you on the line. Surely somebody has some ideas about what we talked about today and how it might influence their practice. If not, then we will call it a day. And I thank you again for what you do. Please join us in 2 weeks when we will be doing Dr. Sipma from UAB will do rehab therapies roles in movement disorders. And so that should be very interesting. And then we're developing now our calendar for 2026. So if you have a presentation you'd like to hear, put that in your email. Or if you'd like to present, put that in your email. We'd love to have you join us. We'd love to have you present your knowledge to other people. Thank you so much again for being here. I'm trying to see, how do we stop